Imagine a medical emergency so severe it literally shuts down the brain. Now, imagine the medical world being completely divided on exactly why that happens. Welcome to This Explainer. Today, we're objectively unpacking two vastly different perspectives on the physiological mechanisms behind diabetic comas. We're going to look at this fascinating intersection where established medical consensus goes head-to-head with a completely alternative theory. So if you've ever wondered how the exact same emergency can be viewed through two totally different lenses, you are definitely in the right place. This central question right here hooks us right in. It frames a medical mystery that both standard guidelines and this alternative physiological model are trying to solve. We're going to zoom in closely on the mechanics of the human body during a severe crisis. How does it lose control? And more importantly, what is the actual biological domino effect that leads to someone losing consciousness? Here's our roadmap for today. First, defining the diabetic coma. 2, the standard medical model. 3, the alternative physiological theory. 4, the role of the liver. 5, conflicting treatment approaches. And 6, critical warning signs. Section 1, defining the diabetic coma. Let's establish the baseline. So, first things first, a diabetic coma isn't just one singular diagnosis. It's actually a critical endpoint that demands immediate, hands-on medical assessment. You're looking at an unconscious, severely confused patient. Maybe they're having seizures, or they're completely unable to swallow. It is a massive red flag, signaling a potentially reversible but absolutely life-threatening metabolic or neurological emergency. Moving on to Section 2, the standard medical model. Let's look at the established framework that guides hospitals worldwide today, starting with how the American Diabetes Association categorizes these emergencies. According to the standard guidelines, diabetic ketoacidosis, or DKA, hits when an insulin deficiency forces the body into ketosis and metabolic acidosis. This usually develops over a few hours to a couple of days. In this orthodox model, the pancreas just isn't pumping out enough insulin, so glucose literally can't get into the cells. Starving for energy, the body panics and aggressively starts burning fat, rapidly dumping these acidic ketones right into the bloodstream. This buildup of acid dramatically alters the blood's pH, which, along with severe dehydration, leads to altered consciousness. On the flip side, the mainstream consensus defines HHS as severe hyperglycemia and profound water deficit, but without the significant acidosis. It's often associated with an acute illness. In this scenario, there might be just enough insulin hanging around to prevent that massive fat burning and acid buildup we see in DKA. But blood sugar levels still skyrocket. We're talking sometimes over 600 milligrams per deciliter. This creates a hyper-concentrated blood state that literally acts like a sponge, pulling water right out of the body's tissues, including the brain. And that severe dehydration is what leads to progressive neurological changes and ultimately a coma. All right, Section 3, the alternative physiological theory. This is where things get really interesting. Pivoting to the dissenting perspective from our source transcript, Dr. Dia Awadi proposes a radically different root cause. Now, you might be thinking, wait a minute, how can you possibly have a diabetic coma with normal blood sugar? Well, Dr. Awadi points out these clinical paradoxes, arguing that severe acidosis can actually happen entirely without high blood sugar or an insulin deficiency. Think about it. Severe physical exertion or starvation can cause ketoacidosis with totally normal sugar levels. Even certain medications can trigger these states completely independently of insulin. So this unconventional model argues that if we can have comas with high sugar but no acid, or high acid with normal sugar, then maybe, just maybe, the core issue isn't strictly that insulin-glucose relationship. Section 4, the role of the liver. Let's break down this alternative mechanism. Think of the liver like the body's main chemical highway. When gut inflammation or toxic stress hits, traffic backs up big time. The liver gets congested and blood literally begins to pool and slow down in the abdominal region. Because that blood is basically stagnant, a vital process called the Cori cycle, which is our metabolic recycling plant where the liver converts pyruvic and lactic acids back into usable glucose, well, it just grinds to a sudden halt. And the result? Those toxic acids rapidly pile up in the bloodstream. In this model, the resulting hyperdynamic circulation starves the brain of oxygen and essential ketones, and that is what actually triggers the coma state. See, because so much blood is trapped in the congested liver and abdomen, the remaining blood circulating through the rest of the body drops in volume, but moves at incredibly high speeds to try and compensate. This rapid, shallow circulation simply doesn't allow enough time for oxygen to be dropped off at the lungs or for vital fuel to reach the brain. So the coma is viewed as the brain basically shutting itself down due to a lack of oxygen and fuel delivery, not just because of a spike in blood sugar.
Section 5. Conflicting treatment approaches. Let's see how these theories clash in the real world.
Because these two models view the root cause so entirely differently, their emergency treatments absolutely clash. It's a perfect example of how your diagnostic philosophy dictates your clinical actions. As you can see, it's the ultimate contrast. Standard medicine mandates fluid resuscitation and insulin, while the alternative theory pushes for total fasting and corticosteroids to reduce inflammation. Now, the official guidelines explicitly state that restoring intravascular volume and giving continuous IV insulin are absolutely central to fixing the crisis. To standard medicine, this condition is essentially a massive, severe drought. So the solution? Flood the system with IV fluids to rehydrate those parched tissues and use continuous insulin to force that glucose out of the blood and back into the starving cells, which shuts down the dangerous production of acidic ketones. But in stark opposition, the alternative view claims that pumping in IV fluids is actually ineffective because of that blood pooling we talked about. They insist corticosteroids are the true key to getting cerebral blood flow moving again. Dr. Alwadi's model argues that adding more fluids to a system where blood is already trapped down in the abdomen isn't going to help. It'll just pass straight through to the urine. Plus, they argue that giving insulin could dangerously lower blood sugar when the brain is already starving for fuel. Instead, this theory suggests using corticosteroids to rapidly knock out the inflammation and congestion in the liver. By opening up the liver, that trapped blood is released, the Cori cycle restarts, and healthy, oxygen-rich blood flow is finally restored to the brain. Section 6, Critical Warning Signs. Let's look at what everyone actually agrees on. Regardless of which medical philosophy is correct, recognizing this crisis early can absolutely save a life. If you see a loved one showing unusual drowsiness, severe dehydration, or that distinct fruity acetone-like breath, do not wait. The body is actively losing its metabolic balance. At this stage, it is a full-blown medical emergency requiring professional intervention, period. You simply cannot guess what's happening inside the blood. Whether a hospital is correcting glucose and fluid deficits following the standard model, or attempting to resolve organ congestion, constant, rigorous monitoring of the patient's internal chemistry is non-negotiable. Frequent bedside glucose testing and serial laboratory assessments are the only way to safely guide a patient out of the danger zone. Understanding both the standard consensus and this alternative physiological theory really leaves us to ponder just how incredibly complex and multifaceted human metabolism truly is. We have the widely accepted model focusing on insulin and cellular starvation, right alongside a highly mechanical model focusing on liver congestion and hyperdynamic circulation. It makes you wonder, right? As medical technology and our understanding of the human body keep advancing, what other hidden pathways and mechanisms are just waiting to be uncovered? Keep questioning, keep learning, and I'll catch you in the next explainer.